Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is menopausal hormone therapy. Mean age of menopause is 52 years, range is 40 to 58 years, and this age is genetically determined and it is not affected by age of menarche, ethnicity, or race. Important definitions are menopause is permanent cessation of menstruation because of ovarian failure. Early menopause is when it occurs between 40 to 45 years. Premature menopause is menopause taking place before the age of 40, and especially it is when there is a bilateral oophorectomy has been done. Then that is called as premature menopause. On the other hand, premature ovarian insufficiency is loss of ovarian function at the age less than 40 years, which can be temporary. Whereas premature menopause is permanent. Causes of premature ovarian insufficiency or early menopause, that is menopause between the age of 40 to 45 years. It can be because of genetic abnormalities such as Turner mosaic, fragile X, premutations, autoimmune disorders, smoking, chemotherapy or radiotherapy, pelvic surgery or hysterectomy, even if ovaries are retained. The important point is menopausal hormone therapy to be given till natural age of menopause is achieved in this group of women with either premature ovarian insufficiency or early menopause. Indications of menopausal hormone therapy are therapeutic and preventing indications. Therapeutic are for hot flashes, genitourinary syndrome of menopause, and osteoporosis. Whereas prevention is only proved beyond doubt for osteoporosis, whereas there is a question mark about CVS protection and about prevention of dementia. Contraindications to menopausal hormone therapy are important, as whenever we want to start this treatment, we should be aware about indications and as well as about the contraindications. Any active liver or gallbladder disease is a contraindication. Known or suspected breast cancer or endometrial cancer is contraindication. Undiagnosed abnormal genital bleeding, that is also a contraindication. Any patient who has a um, cardiovascular disease, including coronary heart disease, cerebrovascular disease, or thromboembolic disorder. Relative contraindications are also important, and these include higher risk states for all these above disorders. Women's Health Initiative or WHI trial. Now, this is a landmark trial, as we have seen so many diseases in gynecology have changed the way we treat the patients, such as McFire trial for hypertensive disorders in pregnancy. Same way, whenever we talk about this menopausal hormone therapy, we should always remember this trial, WHI trial, Women's Health Initiative. It was a randomized control trial which significantly reduced the use of menopausal hormone therapy worldwide. How it did was it was a trial where one group was given placebo therapy and another group of women were given menopausal hormone therapy with oral conjugated estrogen 0.625 milligram combined with medroxyprogesterone acetate 2.5 milligram in women who had uterus. Whereas in hysterectomized women, only conjugated estrogen 0.625 milligram was given. Now, this trial was originally planned for a long duration, for 15 years, but it had to be terminated prematurely in 2002 at the end of 5 years, when the results showed that there was significant increase in the risk of breast cancer whenever estrogen progesterone combination was given. It also, this estrogen progesterone therapy also led to the increase in the risk of cardiovascular disease. So both of these serious side effects were observed, and that is why the trial was prematurely terminated. Now, the results were published not only in medical journals but also in many newspapers, and that resulted in such a defamation of this menopausal hormone therapy that all over the world there was a significant reduction in the use of menopausal hormone therapy, as there was this increased risk of breast cancer and CVD, which was shown in the results of the trial. Further analysis of the results showed that, fortunately, this effect was not seen. Increase in breast cancer as well as CVD was not seen whenever this menopausal hormone therapy was given within 10 years of menopause, or it was given to women with an age less than 60 years. That reassured the gynecologists as well as the menopause societies. That means we can freely give menopause hormone therapy whenever patient or a woman is suffering from severe, moderate to severe hot flashes, or she has a severe genitourinary syndrome of menopause, or there is a risk factor, high risk factor, or she is already having osteoporosis. These are the indications where now we can give menopause hormone therapy, provided the duration of menopause is less than 10 years and woman's age is less than 60 years. Another trial, there are many trials available. If you go through the literature, there are many important trials, especially focusing on this menopause hormone therapy. Another important is ELITE trial, where early versus late intervention trial with estradiol was studied. If menopause hormone therapy was started with a duration of menopause of less than 6 years, with a estradiol dose 1 milligram per day, combined with progestogen vaginal gel, and it was studied with a second group receiving only placebo. What was observed was there was a statistically significant reduction in atherosclerosis in the group which received this menopausal hormone therapy. That means there was an improvement in this group. This effect was not seen with menopause hormone therapy whenever it was started with a duration of menopause of more than 10 years, and that proved that early intervention is better as compared to the late intervention with the menopause hormone therapy. There are certain important concepts which we should remember whenever we want to start menopause hormone therapy for any woman. Unopposed estrogen can lead to endometrial hyperplasia or typical hyperplasia as well as endometrial cancer. That is why estrogen replacement therapy should always be combined with progestogens whenever uterus is present. In hysterectomized women, we can give only estrogen replacement therapy. There is no need to add the progestins in those women. Whenever progestins are given, these can be given either continuously or in a sequential form. Sequential is when the progestins are added only for 12 to 14 days of each cycle. Remaining days only estrogen is given. Now with sequential, dose for medroxyprogesterone acetate is 5 milligram, and for continuous a lower dose is used of 2.5 milligram. Advantage of giving sequential progestins is it leads to predictable vaginal bleeding, whereas with continuous estrogen and progestogen, it leads to unpredictable bleeding for say around 1 year after starting menopause hormone therapy, and then it usually leads to amenorrhea. LNG IUS, levonorgestrel releasing intrauterine system, can also be used as an endometrial protection whenever we are giving estrogen replacement therapy, and the efficacy will be for 5 to 7 years with the LNG IUS. This is important to understand about oral estrogen administration, about especially pharmacokinetics related to oral estrogen administration. There is something which is called as a first pass hepatic effect. Now, whenever estradiol is given orally or any estrogen preparation is given orally, it has an intestinal and hepatic first pass effect. That means whenever it is getting absorbed through the intestine and then it goes to the liver, it gets metabolized to weaker estrogen such as estrone. Estradiol is getting converted to estrone. So bioavailability is reduced to only 10 to 15% of the orally taken dose. Not only that, it doesn't, it reduces the potency of the drug, but because of this first pass hepatic effect, there is a major adverse effect is this, it adversely affects lipid metabolism, clotting factors, and binding globulins in liver. So liver is producing sex hormone by binding globulin and other binding globulin, that level increases. So that reducing in the level of free hormones such as free estradiol or free testosterone or androgen level is reduced. Increase in clotting factors, so that there is a pro-thrombotic action, and there is increase in lipid metabolism also, that leads to more of hyperlipidemia. Oral estradiol has a pro-thrombotic and pro-inflammatory effect on liver. It leads to so much as 5 times increase in the deep vein thrombosis with the oral estrogen. So that is the major drawback of this first pass hepatic effect of oral estrogens. Now we start with each indication to give menopause hormone therapy, such as first is hot flashes or vasomotor symptoms. Second is treatment for this. Second is treatment of genitourinary syndrome of menopause. And third is for prevention as well as treatment of osteoporosis. These are the three clear indications to start the this menopausal hormone therapy. Hot flashes are seen in 75% of menopausal women. These are maximum for 2 years after menopause, but in some women might suffer with these hot flashes for as long as 10 years after menopause. There is a sudden hot feeling followed by profuse sweating, that is called as a hot flash. It leads to daytime fatigue as well as it leads to major sleep disturbances, and that leads to so many times depression and reduction in quality of life in postmenopausal women. These hot flashes are because of estrogen withdrawal, and these are not because of estrogen deficiency, because in Turner syndrome these are not seen. Turner syndrome, there won't be any estrogen throughout life, but hot flashes are not observed. So whenever a woman is subjected to estrogen first and then there is a estrogen deficiency or withdrawal, then only there is an appearance of these hot flashes. Whenever these are present, we need to rule out hyperthyroidism because the presentation might be similar with this. Treatment of hot flashes, first line is hormone therapy, where estrogen therapy is very effective to control these hot flashes. If there is a contraindication for estrogen therapy, then only progestin therapy has been seen to be effective in some women for a reduction in hot flashes. Combination of estrogen progestin therapy is indicated whenever a uterus is present. Combination of conjugated estrogen and bazedoxifene. Bazedoxifene is a estrogen receptor agonist, antagonist, or SERM, and when it is given along with conjugated estrogen, it takes care of moderate to severe degree of hot flashes. Now, if these medications are not effective, then only second line non-hormonal medications are tried because of the serious side effects associated with this, such as clonidine, selective serotonin and norepinephrine reuptake inhibitors, or gabapentin 3-GABAline. For that, usually we need to take help of physicians whenever we want to prescribe these drugs. Non-prescription medications, though not proven by RCTs, are isoflavone supplements or phytoestrogens, soy products, and black cohosh. Lifestyle changes do help in reducing the severity of hot flashes, such as weight reduction. It is seen that obese women suffer more with these hot flashes, and weight reduction helps. Yoga, remaining in a cool environment, and cessation of smoking. Most effective treatment of hot flashes is systemic estrogen replacement therapy. Now, this is ERT to be given in as low dose as possible. It can be given alone if uterus is not there, and it should be added. Progestin needs to be added if uterus is present. Progestin can be given as continuous or intermittent form. Conjugated estrogen 0.45 milligram and bazedoxifene 20 milligram is effective treatment for this if the severity of hot flashes is more. Principle is lowest dose to be given, and the duration of treatment should be we need to try to give it to a minimum duration. OC pills are effective whenever perimenopausal women suffer with hot flashes. Always whenever we start with this menopausal hormone therapy for hot flashes, any hormone therapy, gradual dose reduction helps in preventing the relapse, as otherwise a high rate of relapse is seen if there is a sudden cessation of the treatment. Now, genitourinary syndrome of menopause or GSM, this is second indication to start with the this menopause hormone therapy. This GSM is because of estrogen deficiency. It is seen 5 to 8 years after menopause. So it is seen as a late effect of the postmenopausal estrogen deficiency. It affects labia and vagina. It leads to vulvovaginal atrophy or VVA. It also affects bladder and urethra. There is vaginal itching, dyspareunia or recurrent UTI, urinary urgency can be seen, and overall it leads to the reduction in the quality of life. Treatment of this genitourinary syndrome of menopause is first line is non-hormonal, such as vaginal lubricants or moisturizer. Second line is vaginal estrogen application. With this vaginal estrogen preparations are preferred over the oral because of the minimal absorption and associated less side effects with this. Vaginal estrogen therapy in this genitourinary syndrome of menopause, it has one example is estradiol vaginal cream. It can be given in the form of vaginal cream as 0.5 gram, 2 to 3 times to be applied per week. Or estradiol vaginal tablet, 10 microgram or 4 microgram as per the patient's response. It can be given 2 times a week. Estradiol vaginal ring is also available, which releases 7.5 microgram of estradiol per day, and it is effective for 3 months. Estradiol vaginal preparations have endometrial safety up to 1 year. So for these vaginal local preparations, there is no need to add progestogens if the treatment is given for less than 1 year. It improves urinary symptoms such as urinary urgency, recurrent urinary tract infection, but it does not improve the urinary incontinence. Vaginal dihydroepiandrosterone has also been tried for this genitourinary syndrome of menopause, and it is an effective treatment for vulvovaginal atrophy. Now another sum by the name of ospemifene. Ospemifene is selective estrogen receptor modulator. Oral tablet is available with 60 milligram per day, and it is an effective treatment and safe treatment for vulvovaginal atrophy. Ospemifene. Ospemifene. Next is osteoporosis. What are the high risk factors for osteoporosis? These can be remembered as non-modifiable, modifiable, and high risk factor because of the medical conditions. Non-modifiable are advancing age, race, Asian women are at greater risk of osteoporosis, small body frame, family history of osteoporosis, and early menopause. By definition, I have already told you that early menopause is menopause between the age of 40 to 45 years. Modifiable risk factors are inadequate intake of calcium and vitamin D, either dietary or in the tablet form, sedentary lifestyle, low weight, less weight, smoking, that less weight is lean and thin woman, or especially sometimes there are so many times some fads are there for weight reduction, and excessive weight reduction also is a risk factor. smoking and excess alcohol use. Medical conditions which form the high risk factor for osteoporosis are hyperthyroidism and hyperparathyroidism, rheumatoid arthritis, all conditions requiring oral steroids, and anovulation in reproductive phase. Because of excessive exercise or strict diet, if there is anovulation, it is also a risk factor for osteoporosis. Osteoporosis prevention is important in high risk group for osteoporosis. Calcium supplements, either in the form of dietary calcium or in the oral tablet form, should be supplemented with 1200 milligram per day as the dose. Vitamin D, 1000 international units per day is to be given. Weight bearing and muscle strengthening exercises are important for the prevention of osteoporosis. Smoking should be stopped completely, and there should be reduction in alcohol intake. Treatment of osteoporosis, as well as whenever there is a low BMD is bone mineral density, then prevention is also important. And for that, for these indications, when there is a already there is a low BMD, osteopenia is there, then to stop its progress to osteoporosis is prevention of osteoporosis. And treatment is whenever already there is a presence of osteoporosis, then it is an indication to start with the specific drugs. Apart from this postmenopausal hormonal treatment, hormonal therapy, there are other effective drugs also which are available for the prevention and treatment of osteoporosis, and one of these is bisphosphonates. Bisphosphonates are being used for the prevention and treatment of osteoporosis since last many decades, and the topmost drug is alendronate, which has been used extensively with 35 milligram or 75 milligram tablet orally, and one tablet weekly is to be given. What is most important is it should always be taken with plenty of water, and woman has to remain upright for half an hour after taking the tablet, and no liquid or solid food is to be taken in that half an hour. Other bisphosphonates which have been introduced in market are risedronate, ibandronate, zoledronic acid. Now, if we as gynecologists are not very confident about prescribing this drug, then it should be prescribed in consultation with orthopedic specialist. Otherwise, also our menopausal clinic should have a multidisciplinary approach where we need to take help of physician, cardiologist, diabetologist, orthopedician, and so on. Major side effect of these bisphosphonates is GI distress, gastrointestinal distress. Rarely it can lead to esophageal ulceration, osteosclerosis of mandible, and atypical femoral fractures. Denosumab is the monoclonal antibody which is given as 60 milligrams subcutaneously, one injection every 6 months. Though expensive, it is quite effective. For menopausal hormonal therapy, either estrogen replacement therapy if uterus is not there, or estrogen with progestogen replacement therapy if uterus is present, will help in prevention as well as treatment of osteoporosis by reformation of the remodeling of the bone. SERMs also have a positive impact on this bone health, and these are also used as for the prevention and treatment of osteoporosis. SERMs or estrogen receptor agonist antagonist, that is ERA, one and the same. Tissue selective estrogen complex, which is being used with great efficacy for the prevention and treatment of osteoporosis. This is a azadoxifene, which which has got a additive action along with conjugated estrogen, and that is how this combination is very effective in preventing and treating not only osteoporosis, but also it helps for the treatment of vulvovaginal atrophy, or what we say as a genitourinary syndrome of menopause, and also for the severe, moderate to severe hot flashes also. Now, this is important slide. Here we can see the comparative potency of various estrogens and progestogens so that we get an idea whenever we select a preparation, which preparation to be prescribed to a patient when we want to start with menopausal hormone therapy. Conjugated estrogen with a dose of 0.625 milligram is the standard most commonly used drug as a estrogen component for the hormone post this menopausal hormonal therapy. Even the preparations, even preparations with a lower dose are now available, such as 0.45 milligram or 0.3 milligram are also available, are to be selected depending on what is our goal of menopausal hormone therapy. If it is only for, say, for hot flashes, and if the lower dose leads to the symptom relief, then we should continue with the lowest possible dose. That is one example. Now, for with this usual dose is 0.625 milligram of conjugated estrogen, and it is equivalent to micronized estradiol 0.1 milligram. Suppose we want to select another preparation, then we should have this comparative idea about the how much is the potency. Ethinyl estradiol 5 microgram is equivalent to this dose of conjugated estrogen 0.625 milligram, and it is very important to appreciate that even when we say low dose oral contraceptive pills, these are containing 30 microgram of ethinyl estradiol, and ultra low dose are having 20 microgram. And that is the reason we cannot give OC pills, though these are cheaper as compared to all these postmenopausal or menopausal hormone therapy. We should not be using oral contraceptive pills because it is providing too high a dose of estrogen as well as progestogen with the potential for serious complications because of the drug side effects. Transdermal estradiol 50 microgram is equivalent to this 0.625 milligram of conjugated estrogen. Talking about progestogens, we have already seen medroxyprogesterone acetate is given with a dose of 5 milligram. Whenever we give progestogen as a sequential mode along with estrogen, that means we are giving only 12 to 15 days in a month. But if continuously it is to be given, we give it with a dose of medroxyprogesterone acetate 2.5 milligram. Equivalent to medroxyprogesterone acetate 5 milligram is norethindrone 1 milligram, micronized progesterone 200 milligram, levonorgestrel 0.75 milligram. Now, newer preparations with this menopausal hormone therapy are having newer progestogens, so that desogestrel 0.15 milligram is equivalent to medroxyprogesterone acetate 5 milligram. Dienogens drospirenone each 2 milligram each are equivalent to this 5 milligram of medroxyprogesterone acetate, and that is how we can select depending on the patient's severity of symptoms and our goal of the menopausal hormone therapy. We can select a combination of estrogen and progestogen whenever there is a presence of uterus. If no uterus, then we can proceed with only estrogen replacement therapy. There are specific indications for non-oral supplementation of estrogen, especially transdermal matrix estrogen replacement therapy. Now, matrix is a form of transdermal patch which is better tolerated by patients with less cutaneous side effects such as irritation or itching. And it is better tolerated. This transdermal matrix patch is better tolerated even in hot and humid environment also. So nowadays, whatever transdermal preparations available are transdermal matrix estrogen replacement therapy. These are specifically indicated when a woman has high risk for deep vein thrombosis, obesity is present with metabolic syndrome, or a patient has diabetes as well as hypertension, or hyperlipidemia, or she is a smoker. That means if there is a risk factor for cardiovascular disease, then in that case, we can say in simple manner, in that case, transdermal administration is safer as compared to the oral administration of estrogen replacement therapy. Whenever aim of our giving menopausal hormone therapy is to improve libido, In that case also transdermal is better, because with oral, what is happening with oral is there is increase in sex hormone binding globulin, and this SHBG leads to fall in androgen level. And androgen or testosterone level in the circulation mainly decides the sex drive or the libido, and that is the reason transdermal administration is better for this indication as compared to the oral administration. Coming to SERMs or ERA, now this is a selective estrogen receptor modulator and estrogen receptor agonist slash antagonist is one and the same. That we need to understand. If you see newer editions of the textbooks, then the terminology which is used is no longer ACRM or selective estrogen receptor modulator or SERM. Instead of that, the terminology which is used now is estrogen receptor agonist oblique or slash antagonist. Now, this terminology is being used because the drugs are such that whenever we provide the drug, it acts as agonist at some tissues with estrogen receptors, and the same drug acts as antagonist at other tissues in the body over the estrogen receptors in those other tissues. And that is why the terminology which is used is estrogen receptor agonist slash antagonist. Tamoxifen is the one which is being used since last many decades in breast cancer, but unfortunately there is an increased risk of endometrial hyperplasia and endometrial cancer with the use of tamoxifen. On the other hand, raloxifene doesn't have this complication of risk of increased endometrial cancer. Risk is not there. It protects against breast cancer, and it is a drug which helps in prevention as well as treatment of osteoporosis when provided as 60 milligram per day dose tablet. There is an increased risk of DVT, deep vein thrombosis, and hot flushes do reappear or increase in the severity whenever a woman is on raloxifene. That we need to understand. Next is ospemifene. Ospemifene is this estrogen receptor agonist antagonist ERAA, which is effective for vulvovaginal atrophy as a part of the genitourinary syndrome of menopause. Bazadoxifene, it has, as opposed to raloxifene, it has additive action whenever it is combined with conjugated estrogen. That means it supplements the action of conjugated estrogen, and that is why it is given in combination with conjugated estrogen, and it is very effective for moderate to for prevention and treatment of osteoporosis, for moderate to severe vasomotor symptoms, as well as for genitourinary syndrome of menopause. This is an emerging option where there is no need to add a progestogen, because this bazadoxifene has got antagonistic action on the endometrial receptors, and that is why it provides endometrial protection when it is combined with this conjugated estrogen. It also helps in prevention and treatment of osteoporosis, vasomotor symptoms, and improvement of genitourinary syndrome of menopause. These are the risk factors for CVD. Now, why we should know these risk factors for CVD are, we divide these as non-modifiable, modifiable, and those medical conditions leading to cardiovascular disease. The reason is we know that this menopausal hormonal therapy is not going to help us to reduce cardiovascular disease. That we have already seen, especially with the Women's Health Initiative trial. If the this therapy started later in life in elderly women more than 60 years, or whenever duration of menopause is more than say 10 years. But we need to know these risk factors because we can advise the patient for to reduce the modifiable risk factor impact by reducing the weight, control obesity, by cessation of smoking, and to do more exercises so that to be to avoid this sedentary lifestyle. That is how that will lead to the uh, prevention for against this cardiovascular disease. Good control of hypertension, diabetes, hyperlipidemia also helps in this reduction in the cardiovascular disease in postmenopausal Whenever we prescribe this menopause hormone therapy, what is the main concern is increase in the risk of breast cancer, which was seen whenever with especially with the landmark trial, as we have already seen with the Women's Health Initiative trial. Whenever MHT is given for a long duration, prolonged MHT, which is defined as given for more than 5 years, it has been seen that there is increased risk of breast cancer. Risk is more whenever progesterone is added to estrogen, and it is not seen when only estrogen is given, especially whenever there is a hysterectomized woman and only estrogen is given, then this risk is not seen. Tamoxifen, raloxifene reduce the risk of breast cancer, but unfortunately, tamoxifen is associated with increased risk of endometrial cancer. So, initially it was thought that menopausal hormone therapy might reduce the dementia. Dementia is commonly seen in elderly women as compared to men. It is more commonly seen in women, and that is why it was thought that supplementation of the hormones might lead to reduction. But it has been seen that menopausal hormone therapy, on the other hand, increases dementia whenever estrogen and progesterone combination therapy is given. It is not seen when estrogen is given alone. To summarize, menopausal hormone therapy can be given safely in women less than 60 years and in women where the duration of menopause is less than 10 years. Non-oral estrogen administration is safer in high-risk women. Low-dose menopausal hormone therapy to be given for the treatment of hot flashes, and it should be given for the shortest possible duration also. Vaginal estrogen replacement therapy is effective for genitourinary syndrome of menopause. Osteoporosis prevention and treatment is possible with menopausal hormone therapy, and it reduces the associated morbidity and mortality because of the fractures seen in elderly women. Safe duration of menopausal hormone therapy is less than 5 years. Whenever it is given for greater than 5 years, it is called as it is labeled as a long duration of menopausal hormone therapy. Thank you so much. I want to thank postgraduate students for actively taking interest in this PGOG, postgraduate class in obstetrics and gynecology. One request is please share this YouTube channel link with your friends so that so that it can benefit more and more. I want to help as many postgraduate students as possible with this YouTube channel. That is the main aim of creating these videos, and that is why please share the link with all your friends. Thank you once again.